Our knowledge and truth for a healthy living is a must. Here are the experts. Here are the facts. Here is what we testify to and speak. This is We Shop Talk.
Welcome back to We Shop Talk episode 7 as we address topics about obesity. And power is knowledge and knowledge is power. So share it with other people and pass it on. Dr. Toby?
As we move on to this next segment for our viewers, we want to bring on and introduce to you one of our other clients, Mrs. Jackson, who will also tell us a little bit about herself and her story. We also have joining us Dr. Cassandra Cotton, who is a psychologist here in the city, to shed a little more light on issues relating to the mental health aspect of folks dealing with obesity, folks losing weight, and what are the consequences of that in terms of one's mental health. Ms. Jackson, so good to see you, ma'am. We appreciate you coming out on this cold Sunday afternoon.
You're welcome.
We appreciate you. What's been your story with your medication that we've been talking about, Ms. Jackson?
When I first started going to your office, I think I was like about 184, 185 pounds.
Mm-hmm.
Basically, I was if I see it, I eat it type of person. If it's there, it looks good, I eat it. But I've always loved vegetables. And so when I got with Miss Lawson, she was telling me different things I needed to do with my weight loss and my diabetes. And so she put me on Ozempic. And I started taking it. And I've been on it about 4 or 5 months now. Mm-hmm. And I've gone from like 184 and I'm down to the low 140s.
Mm-hmm.
So the only bad side effect I had was constipation. Mm-hmm. And with a little help, I drink this tea that Miss Lawson told me to get, but sometimes I have to take a laxative. Mm-hmm. I'll be honest with you. But other than that, I've lost all this weight, and I've gone from a size 14 down to an 8, and I got fit in my daughter-in-law's size 6 pants the other day. So I'm thankful for that. I am truly blessed for taking this but I used to be very slim. All the time growing up, I was such a tomboy that I couldn't keep weight on me. And when I had my oldest son, I gained several pounds, more than, I was up 200 plus. And after I had the baby, my doctor then said, "Oh, you'll never go back to your size." So I believed him, so I just, why worry about it? Mm-hmm. I just ate whatever I wanted to. I stopped exercising. I just stopped everything. And as I got older, it told on me. Mm-hmm. And I'm thankful that I met you and Miss Lawson, because now I am getting back down to a decent size. I mean, at my age, I'll soon to be 80.
You look fabulous.
Yes.
You look fabulous, Ms. Jackson. Absolutely
I
fabulous.
will soon be 80, another month and a half. And I would like to get down to it. I'd say maybe 130s, 140s.
And to your point, Ms. Jackson, thank you so much for sharing that story. It's the fact that we're saying that there is no limit in terms of age. Mm. There is no restriction. Whether you're a young whippersnapper or you're an elderly, you can definitely benefit from these medications. Let me identify very quickly, just again to recognize Dr. Dubeson, consultant endocrinologist here in the city, in Atlanta, office based out of Lawrenceville, been a consultant here for many, many years in the city. Ms. Lawson, practicing a physician assistant with South Dakota Family Physicians, has been in practice a long time. Again, to recognize Mr. Stanley Scott, who has also shared the story. I looked at with Mr. Jerry Goolsby. But let's turn our attention very quickly to the mental aspect of all of this. So we have joining us Dr. Cassandra Cotton, like I mentioned, who is a psychologist here in the city, who will tell us a little bit about the work that she does So all of a sudden you're losing 50, 60 pounds. How do you deal with that? We also do know that these medications too, in some people, can also increase the incidence or the likelihood of going through with depression. How do you deal with that? And have you been dealing with patients in your practice that may have dysmorphia that Ms. Lawson had alluded to? Please, Dr. Cotton, please tell us what you do and what you bring to our audience today.
Thank you very much, Dr. Kintobi. I am Dr. Canton. I'm a licensed psychotherapist practicing in the Conyers, Rockdale County area. And yes, I do have clients on my client load who have been on weight loss medications. My primary premise is that if your body is not right, your mind will not be right. Mm-hmm. So one of the first things that I do when I get a new client is I inquire about their eating patterns, their sleep patterns. And what I'm realizing and learning from clients who are on weight loss medication is that they report better sleep. They report a change in their eating habits. And with that change, coupled with the weight loss, they're looking good. Loneliness seems to disappear. They're going out and they're not really manic, but they're more on the happy side of life and a little bit more upbeat. And I was observing a lady who came into my office the other day. She was bopping to the music and everything. And okay, we're changing now. And they have a lot more courage in terms of going out, being more social, and have less issues with body dysmorphic issues. So there is emotional aspect to this whole weight loss thing.
Now, the piece about depression, because I think there's a label that, isn't that there, Dr. Odubeson, about making sure that patients are screened for depression before, during, while they're also taking the medication. Is that something that you've seen a little bit? Because I know, Ms. Lawson, you mentioned that in the first segment about the mental piece, the mental health piece, depression. Is that a good percentage that you're seeing? And I'd like for both of you to comment on that.
Well, I would say out of the 400 patients that we have, I would probably have, maybe it's a very small number, 3, 4 with the depression, and with the body dysmorphia, or maybe like 10, you know. And then we try to unpack that. We do the screenings, and then I move forward with referrals.
So one of the things that's interesting is that, in fact, if you look at patients with diabetes, particularly patients who have uncontrolled diabetes along with obesity, there's a higher prevalence of mood disorders in these patients. And so you have to be very careful when you put people on therapy, not assuming that it's the therapy that's caused the problem, because in fact, they may have had the problem early on. As a general rule, I think what Dr. Cotton just said is absolutely true. A lot of patients with the achievement of weight loss suddenly become much more physically active. For a lot of them, their mental health issues, which may have been there before, improves. There is obviously a small percentage of patients in whom dramatic weight loss may be associated with some form of mood disorder. And I think it's important for us to always ask about this and refer those patients for appropriate therapy. But I would say in my experience, that represents a very small percentage of patients who have been successfully treated with GLP-1 therapy, whether in fact in combination with diabetes or without.
And that's so true. So I think the take-home message for our audience is that if you're on these medications or medications like it, the importance of not just staying away 3 months, getting the 90-day supply, not going back again to see your provider should be discouraged. Because the importance of going there every 2 weeks or every 4 weeks is to ask those questions. How are you doing? They're looking in your eyes and getting a feel for how you did. Dr. Connie just said someone was walking and dancing to the music. You don't have to ask how they're doing because you can see already. You know, but if you see somebody that is down, maybe the 1 out of 100, that we don't want to miss that. Or somebody that may potentially develop pancreatitis, we don't want to miss that. It's our responsibility as a care provider to be sure we're checking all those boxes to say, how are you doing? How are you feeling? Asking those questions and then checking you out. But let's segue very quickly. We've said medications are expensive. Not all insurance companies cover them. People are looking for easy way out, and there's a lot of money to be made by making compounded medications, Dr. Dubes and Ms. Lawson. And so what have you seen in terms of people using what is not FDA approved? So it's semaglutide is out there, people will sell it. Instead of something costing $1,200, it's $120. And would you rather pay for $120 but not knowing what you're getting? How are these medications made, Dr. Dubes?
Okay, so I think people need to understand there are some legal aspects to this. When you as a pharmaceutical company develops a new drug, you do clinical trials, you show that to the FDA, you tell them what the side effects are, you tell them how the drug works, what the drug does. The FDA looks at that data and says, okay, great. Ozempic, we're going to approve you to be used for the treatment of diabetes. Now, because you have a patent on that drug, no other company can come by and make that drug because you have a patent on it. Except there is a small little rule, which is that if there is a nationwide inadequate supply of the drug, the FDA allows compounding pharmacies to now make the drug if it is felt essential. And so this is what happened with Ozempic. Ozempic, the generic name for Ozempic is semaglutide. So there was a point where, in fact, the supply of it dramatically was way below the demand, both for people with diabetes and for people who wanted to use it for weight loss. And so you had a lot of compounding pharmacies making semaglutide. The challenge is exactly what you said. You're not really quite sure, are you getting just semaglutide or are you getting something else? Because remember, when a pharmaceutical company makes a drug, before it gets it out to the public, quality control standards have to be met. The plant that makes the drug is scrutinized by the FDA, so you know that you're getting the correct compound. When a compounding pharmacy makes that drug, you don't really know what you're getting. And in fact, and we've had it, I'm sure you've had it in your practice, we've had several patients who thought they were getting the real thing, but got stuff that turned out to have side effects. Now, what is the scenario now, January 2025? It turns out that there is no shortage of Ozempic, Mounjaro, Wegovy, or Zepbound. So no pharmacy is allowed to make a compounded form of GLP-1. And if they do make it, they might get into trouble because technically it's now illegal. But I would just say this, based on our experience, and we have, just like you, hundreds of patients who have been on this drug very successfully, I would discourage anybody from getting compounded GLP-1 therapy simply because you're not really sure what you're getting. And you may be the one person who gets something that has some impurity or has something else in it that doesn't agree with you and leads to complication.
And it's also interesting, Dr. Besson, Ms. Lawson, too, that it's about technicalities and looking for loopholes in the law that allow some of these things to happen. I called some of those compounding pharmacies. I picked up the phone because they send us information. Oh, you can get semaglutide for half the price. I called to actually talk to the pharmacy or whoever owns those companies. Nobody returned my call because they are not FDA approved, but there is a clause that says that they may be allowed based on the things I just described. But now that we're moving away from that, we had a patient who fainted. He had syncopal episodes multiple times before we realized it was a semaglutide, which was a generic form, or not a compounded form that he was taking. Right. That was but his own argument was, I need this medication. He had lost about 60 pounds, but we just could not quantify exactly what he was getting, and we had to stop him from taking the medication. Yeah. I mean, sadly, and we're still trying to look for ways now to get his insurance company now to cover it. Maybe going to 2025, maybe we'll be successful. Ms. Lawson.
But that goes back to, because I would see prescriptions for a compound semaglutide come through and I wouldn't approve, but it goes back to patients who should qualify, who needs the medicine, do not have access to the medicine. So like you said, they're trying to find loopholes because they need this to lose the weight. And so until we get to a point where we expand access, we make it affordable for patients, then I can see this happening. Because when you talk about beauty, let's talk about beauty. Beauty, yes, is an eye of the beholder, but everyone wants to look good, right? Everyone wants to have a certain figure, whether it's, what we see on TV. People want to look good.
Yes.
So when we talk about that, how do I achieve that? Okay, my insurance company not paying for it. Oh, but I know such and such who got it. You go to this compound pharmacy, and like you say, we do not know what we're getting. You don't know if you're just getting saline. If you think you're getting semaglutide. So I think it goes back to what we were talking about earlier. At the end of the day, we need to lobby, we need to mobilize, we need to talk to our local officers, our legislators, our senators to try to make an impact and try to get some things dissolved.
Thank you so much. And along those lines, Senator Bernie Sanders, the senator, actually led a congressional hearing at some point to figure out exactly how much it cost to make one vial or one pen of semaglutide, and the numbers are staggering. Yeah. In terms of what they figured out, it was probably almost 1/100th of what the cost is out on the market today. I don't want to put numbers out there, but you can go and do some research and find out how much it costs to make one versus how much it's been sold for. Again, we understand the issue of the patents and the fact that these companies need to be commended, but when the cost is there's so much disparity across countries, it leaves us a lot of questions in the United States. Mr. Scott, now we're going to come to Mr. Goldsby. Have you had any issues with coverage with your insurance over the time period that you've been on one of these medications, sir?
No, I haven't. Matter of fact, when I first started taking it, I was paying maybe $40 a month. Mm-hmm. Now I pay $11.20 or something.
Okay. So that's absolutely amazing. Mr. Goldsby?
For me, I went to get my prescription filled, and it was $704. Started the new year. I started a new job, even with a new job and Medicare, which Medicare don't allow for discounts or coupons or anything like that. So for me, it's become very expensive. So, but
now, is that because you're now in the donut hole? You have to spend so much before they start covering?
No, just a minute, quickly. There is no more donut hole starting from 2025. Donut hole.
Well, what I mean is you have to spend so much.
Deductible.
And my A1C has dropped really low, so I don't know if they're looking at the lab work. All my lab work was really good, so my A1C, I think the last time this week was 5.3.
That is correct. Yes. And so to your point now, because it's a new insurance, we did say that we're going to try and do the pre-authorization. Right. Because once there's that diagnosis, yes, the reason why the A1C is so good is because of the medication. Yeah. Not that diabetes is gone.
Right.
We're treating it and we're getting good results. I think we should be able to still do, and this is where extra work comes to us as providers. Sure. What is called pre-authorization. Right. Some pharmacies are beginning to do that now, which is taking a lot off of our shoulders. So we work with some of those pharmacies that do the pre-authorization. They know the verbiage that has to be used, and they get the paperwork to them. Ms. Jackson, has there been any issues with your coverage in terms of medication?
No.
Okay.
They pay for everything. The only thing I have to pay for is I do pay $25 for the Ozempic.
Okay.
But other than that, I go there, they say nothing.
Wonderful.
Yes.
Wonderful. So for the Medicare patients, I think that's probably the case across the board with diabetes. It wasn't like that at the beginning of 2024, but that has changed and improved. And so we're seeing better coverage. You had something on your mind?
Yeah, I was going to say, one of the most fundamental aspects of this is if you have diabetes as a diagnosis, please retain diabetes as a diagnosis for life. Why? Because even when you get to Mr. Goldsby's scenario, where in fact your blood sugars have come down, you have excellent control, you have a normal A1C, that diagnosis should be retained because that is your access to this medication. The minute you take that diagnosis off, then Ozempic is not going to be covered anymore. So once you have a diagnosis of diabetes, you want to retain that diagnosis, even though now your blood sugars may be perfectly normal. retain that diagnosis because that will now give you access to all of the diabetes medication.
Well said, Dr. Grayson. Now, Dr. Contin, for those 1, 2, 3, 4, 5, 6 patients or so out of 100 or out of so many that we see that may have mental health challenges, what are the signs or things they need to look out for? We know the numbers are not too large, but what are the kind of things they need to be looking for?
Usually, it's not the people with thought disorder that I hear from, are those with emotional disorders, the ones with the depression, the bipolar, those are the people. And so, like I said, I usually ask about their sleep pattern. I ask about their eating habit, exercise, water intake, and those are things when they start to go down in any way or be affected in any way, I know something has gone awry.
Okay.
But definitely you don't get to deal with body dysmorphic issues with them. And right now what I'm doing, I don't prescribe, but those who are on medications, I'm redirecting them back to the psychiatrist to get the medications reevaluated for lower dosages because it's working better. But one thing that I also look out for, when they start to feel that good, chances are they start to feel like they should change their diagnoses. I don't need medications anymore. And that is really not a good thing. You stay on your medication. Even if it's not working, go back to the prescriber and get the titration you need or the correct medications that is required. But they want to get it, I'm feeling good now. I can party, I can do things. I don't need medications. You do need them.
And we're going to come very quickly to just finding out from Ms. Jackson, Mr. Scott, and Mr. Goldsby, what you've loved the most about being on this medication. But before then, we're talking about Ozempic and Wegovy and Zepbound and Mounjaro, injections that you take once every week. Remember, this research has taken 20 to 25 years to get up to this point. When we started with medications like Byetta and Victoza, you had to take these shots every day. The reason why you can take these medications now once a week is because it takes 6 days to 7 days for the medication's dose to be reduced in your body. And it stays that long, which is amazing in terms of the technology. But for folks that are very leery about taking shots, Ms. Lawson, Dr. Dubeson, are we looking down the road where there might be pills that people can take by mouth? We know there is one that is approved now in Rybelsus for semaglutide. What has been your experience with that? It's not necessarily approved for weight loss, but we know that at the maximum dose of 14 milligrams of that medication, you can get the same weight loss at 0.5 of Ozempic.
Yeah.
Where do you see the research? Are we going to get to the point where we can take a pill every day?
Yeah, so it's a very interesting point. So you have a drug called Rybelsus, which is exactly the same medication that is in Ozempic, semaglutide, but which you take once a day. You have to take it by itself on an empty stomach and don't take anything else for 30 minutes. But it is effective. But the challenge with Rybelsus is that it doesn't give you the highest degree of weight loss and A1C drop that the higher doses of Ozempic will.
Correct.
But in fact, what has changed is there are now clinical trials looking at much higher doses of Rybelsus. So for example, Rybelsus currently maxes at 14 milligrams. In fact, there are studies now looking at 50 milligrams of Rybelsus as an oral therapy. I can say this because this is public knowledge. You have a company like Lilly that makes Mounjaro and Zepbound. They have an oral form that is in clinical trials right now. It's not approved yet, but it's in clinical trials. And what they have shared so far would suggest that it's pretty effective. So I think over the next year or two, not only are we going to see even better options in the injectable GLP-1 therapies, but we are actually going to see oral therapies that are able to give us the same benefit that the injectables are currently doing.
How do you get your patients to take shots, Ms. Lawson? Folks walk on in and go like, I got to take a shot every week?
No. But the irony is that a lot of patients who are diabetics, they come in already on insulin. And so when I introduce the program or we start, my goal is to kind of be able to reduce the amount of insulin that we're taking, you know? And so wouldn't it be great if we could reduce the insulin and we're just taking a long-acting and Ozempic, or we're just taking fast-acting and Ozempic, or we're just taking Ozempic Ozempic, you know. But it's not just the medicine. Of course, they have to do their part too, and that's with their diet, you know, their exercise and nutrition. When we talk about the Rybelsus, we have a couple of patients who like the Rybelsus because they're afraid of injections. They just don't want to do the injections. But just as you stated earlier, you do not get the maximum benefit with the weight loss as well as the A1C reduction. But I don't have an issue with the shots. The patients who run around like the kids, you know, in the pediatric office, you know, I let them know that it's a very small needle. I should give them an example, you know, and then once they say, oh, you did it, I didn't feel it, you know, then it's all good. And plus, once they see the results, then they're ready to do the second one the next week. So we're good.
Thank you so much, Ms. Lawson. Mr. Scott, is there anything you would like to do differently looking back? Or what has been the most rewarding part of this? We know the weight loss is definitely very important. We're talking about double digits, 50-pound weight loss. Is there anything you would like to do differently looking back over the last 6 months?
No, everything's good. I don't see I don't have nothing bad to say about it.
Not even the clothes?
Well, one thing I did though, my wife always had drove a Mercedes, and I always drove a big truck because I do landscape work.
Yes, sir.
So I went and bought another Mercedes for me.
I love it. Fantastic. Mr. Goolsbee, same question to you, sir. Anything you looking back that I'd like to do differently, or what's been the biggest piece that you love about this, apart from the weight loss?
I don't think I would do anything differently, but as Dr. Lawson was saying, I was terrified of needles. Blood and needles just terrified me. So it was difficult at first to inject myself with a needle, but my wife sort of helped me with that. She said, oh, it's not going to be that bad. And I started doing it, and now I'm not as afraid of needles as I was before I started the program.
But to me, the needle is it's a little bitty.
It is.
I don't like a long needle.
I don't like any.
I can handle that.
So size matters.
You don't
very
vary. Don't much business.
Ms. Jackson, same to you, ma'am. Anything you'd like to do differently looking back? The microphone for Ms.
Oh, maybe I would like to have started it sooner.
That's right.
I've always been very active. I'm still able, I bowl twice a week.
Fantastic.
Now, I can't walk like I used to. I used to walk, about 4 or 5 miles every other day, but I can't walk like that anymore. But other than that, yes, I wish we'd have had this sooner.
Right.
And maybe like years ago when they first told me I had diabetes, if we'd have had it back then. I won't say I wouldn't have diabetes, but I would say I probably would have been much better off if we'd have had it back.
Good point.
Back in the day.
Thank you so much, Ms. Jackson. And again, we do know, and just for our audience, that we have said as part of this discussion today, obesity is a public health crisis in America. The numbers tell us that. We have said too that the environment where we live, work, and play also has a big impact in terms of why obesity has become a public health pandemic, a public health epidemic in the country. We've also said too that structural racism and interpersonal biases, even amongst providers, also has a role to play in why we're seeing this as a scourge now, and that it takes all of us as a community to be sure that we're very sensitive to people and that we're relating to obesity as a chronic medical condition. If you see somebody that's hobbling, that has an ankle sprain, you'll be sympathetic to them. It's the same exact way for someone that might be struggling with their weight concern. And it's been very frustrating. For a lot of people for many years, because we never had regimens of medication that will make a difference without having side effects. And we can go down the memory lane, Ms. Lawson and Dr. Odubese, about what we've used over the years. A lot of medications had to be pulled off the shelf just because of side effect profile. And just to get us to where we are, and we've said this new medication, class of medications, GLP-1s, is not just about weight loss. It's about the fact that for people who are struggling with alcohol use, for people who are struggling with cigarette smoking that want to quit, we're seeing good results because this affects the same part of the brain in terms of dealing with those addictions. We're seeing that these medications help with inflammation generally across the board. So if you have issues with pain and chronic pain, it's helping. For even dementia, there's good data now that is showing that this might be compelling in helping to slow down the progression of dementia. We're beginning to scratch the surface. There's still a lot underneath that. This is the tip of the iceberg. And that is why for our clients and for folks in the African American community, in the Black community, when you hear about clinical trials, let's try and get involved. Let's see how these medications affect people of color. And that clinical trials are not necessarily a negative thing if you have your providers encouraging you to, because the data that we're getting will help us to say this works for Black people, this works for white people, maybe differently, and to kind of understand. So more and more of us will need to get involved in trials like this, particularly when we're seeing the results as stunning as what we've seen with this medication.
I would say two things, two very important things. Number one, if you have diabetes and you have never been offered GLP-1 therapy, you should ask your provider why not. The reason I say that is that right now, if you have type 2 diabetes, which is what 95% of people in the African American community have, if you have type 2 diabetes, the single most effective therapy that we have is GLP-1, Ozempic or Mounjaro. If you are on multiple shots of insulin, you are on 4 or 5 medications for diabetes, but you have never been offered Ozempic or Mounjaro, you should ask your healthcare provider why not, because that is the most effective therapy that we have. And over and beyond the weight loss that we've talked about, it has benefits in bringing your blood sugar levels down. It has benefits in reducing your risk of having a heart attack or stroke or certain forms of cancer or kidney disease or heart failure. So every diabetes patient, everybody who has type 2 diabetes, which, as I said, is what 95% of diabetes patients in the African American community have, every single one of those patients should be considered for a GLP-1 therapy at some point.
I totally agree. I want to say thank you for having me. My colleagues have pretty much summed it up, right? We do know that obesity is a problem. We see the numbers are continuing to rise. The thing is, or the question is, even if you do not have access to the medication, we know the number one treatment is always diet and exercise. So we can start with ourselves. We can start with the reduction of carbs. We can increase our exercise. We can do things that we know we need to do to help with reducing our glucose levels, right? At the end of the day, like we said, getting in touch with our legislators, our councilmen, our congressmen, as well as making sure that at the end of the day, we fight for what we know is right. Because right now we do not have access, or especially in the Black community, we don't have equal access to medication. And I just love the fact that with the weight management program and the way things are going, we've been seeing great results. We've been able to get patients to reduce certain medicines they're on, blood pressure medicines, as well as diabetic medicines. And I think we know that this is not going to stop. It's going to evolve, and I'm looking forward to see what the future holds. If you have any questions or you're a viewer out there and you would love to see us at South DeKalb Family Physicians, you can come see me on Thursdays. I'm there, and let's talk about it, because it starts with the conversation first.
I really thank you for the opportunity to be here and share with this great panel and whoever will get to hear this. As I have come to understand, it seems like there's a lot more serendipity in all of this work that people are doing. But most important, I'd like to say that I look forward really anxiously for any research that would go to support the effect of these medications on people's emotional, mental, and spiritual health. Again, I thank you all.
And so there it is. It has been a wonderful evening sharing information with Dr. Akintobi and his distinguished medical professionals and his guests for sharing your testimonies. We thank you for that. And you have been given a lot of information, so we encourage you to share with others. So knowledge is power, and There you have it. Good evening and good night.
Now that you heard the facts, apply the knowledge. Contact your doctor or healthcare specialist. Scan the QR code to provide more information on today's talk. See you on the next We Shop Talk.